Good morning and welcome everyone to the WellMed Charitable Foundation Caregiver Teleconnection series. Today we have an expert on how to determine what level of care someone with Alzheimer's and or dementia needs. And her name is Candance Ramos, and she's going to tell us a little bit about herself and then start her presentation.
Hello, everyone. Thank you so much for joining today. I'm so excited to be here and be teaching on such an important topic, especially with the differences between the different levels of care. I know it can be very easily confusing. I have worked at VITAS for almost 7 years now, and a lot of my work has been around educating caregivers, discussing the importance of advanced care planning and advanced directives, having those conversations sooner rather than later, and then really providing veteran and community resources and support. So I do as much as I can every day to make sure that caregivers have every tool that they can have, especially for their loved ones at end of life. So thank you so much for having me today.
Thank you.
Let me share my screen.
The sound of technology.
Can you see it?
Looks good.
All right. So again, I'm going to be speaking about home health versus palliative care versus hospice. And the objective of my call today is to provide information about different levels of care provided at home, to include palliative care, hospice care, and home health care. I'm going to start off with a little personal story and a little timeline of something that I've experienced recently in my life with my grandmother that passed away earlier this year that suffered from dementia. And I'm going to use this to kind of paint the picture of when hospice could have been put in place and kind of the trajectory of what transpired as different complications came up with her dementia. So Mima's story. Mima is a 91-year-old with 8 children, and I'm taking my timeline to October of 2022. She had 4 daughters providing 24/7 in-home care on a rotation, different days during the week. Daughters in October had personal life events happen and needed additional family members to stay with mom. So they first reached out to the brothers. And of course, as you all probably know, men are not that comfortable in being caregivers, or especially not caring for someone with dementia that they haven't been around for a long time. My aunts have been providing care to my grandma for a couple of years now. And so they knew all of the things that have changed and everything that has overcome, whereas the sons were not very as familiar with the care that mom needed. So during that time, the granddaughter raises up her hand and says, "I'll stay with Mima." And I stayed with her from a Sunday through a Thursday. So from the first night of me staying there, Mima did not sleep for 24 hours straight after other Sunday visitors left. So my dad, my stepmom, my brother and sister, my other sister, they all came that weekend before I got there to say their hellos and spend their time visiting. She ate minimally the entire time that I was there, even with multiple cues to eat. So I would remind her, "Hey, did you eat something, or do you want to eat something?" I'd leave food out on the table for her to grab herself. And she did not really eat at all the entire time that I was there. She had forgotten to order a refill on her medications. So she kind of ordered it once she realized that she didn't have any more. We made a call to the pharmacy and I went to go pick them up because she does not drive. She couldn't drive. She doesn't have a driver's license. So luckily I was there to be able to do that for her. She also experienced moments of hallucinations of other people in the home that were not there. And actual events happening that there was no one else in the home besides her and I. Fast forward to early December, My grandmother misplaced all of her medication. I bring up to my uncle that I think that it's time for hospice. And he says that he'll talk to the sisters about that decision. On December 24th, as everyone's getting ready for Christmas weekend and everyone gets together to go to my grandma's house for Christmas, she had a fall. She was taken to the ER and it was discovered that she had fractured her hip. The physician stated that surgery would be the best option, and they've done it all the time. Tons of hip fracture surgeries, and she'll be fine. The granddaughter again says surgery is not a good idea, as Mima will not remember that she had a fall or that she had surgery. And there's a 50% mortality rate for dementia patients after a fall within 6 months. They went ahead with the surgery anyways. My grandmother was then discharged to a skilled nursing facility for rehab. The daughters stayed with her at the facility 24/7 to prevent Mima from having a fall on the facility. And you might ask yourself, wait, she's in a facility, how would she fall? Bed rails are not allowed in nursing homes, skilled nursing facilities. So someone with dementia can't remember that they can't get out of bed themselves. They can't remember that they had surgery. There's a high risk of falls. My grandmother wanted to be home. I and my father requested another hospice bring up hospice again. And the physician in the skilled nursing facility recommended home health. My grandmother was discharged home on home health on January the 11th. And on January the 15th, she started declining at home. My aunt called 911. She was resuscitated and intubated. She died later on that morning after my aunt decided that it was time to move forward with her time being done. So that's kind of my story that I've experienced recently. And I wanted to share with you guys true life, because I know that, for my aunts, when I said how come not hospice? How come not hospice? And yes, I'm a hospice advocate because I work for a hospice organization. She said, we don't understand the differences. We don't understand the differences in the level of care. And there's not really anyone that takes the time to discuss the differences. So here I am today, excited and ready to discuss these differences with you guys.
Thank you for sharing.
So when we look at the goals of home health, the goal of home health care is to treat an illness or an injury. So an example for an advanced Alzheimer's dementia patient could be sepsis. So maybe they had a urinary tract infection or some kind of infection or a wound that ended up going into the bloodstream. Rehabilitation from a surgery. So yes, like the example, a hip fracture, pneumonia. So the goal is from home health is to help patients get better, regain independence, and become as self-sufficient as possible. It's not usually a long time service. So when we're looking at home health is around the skilled level of care that's being needed, not the diagnosis. So again, my grandmother was not on home health because she had dementia. She was on home health because she had a hip fracture, and we were trying to help her regain her independence and become as self-sufficient as possible as she was before she had the fall. So Medicare Part A covers hospitals, and Medicare Part B is a medical insurance covers eligible home health services like intermittent skilled nursing care, physical therapy, speech language therapy services, and more. Medicare does not pay for 24-hour-a-day care at home, meals delivered to the home, homemaker services, or personal care services. All of those things are paid for privately out of pocket. So when we're looking at the skilled care, who is eligible for home health? So patients must be under the care of a doctor and must be getting services under a plan of care established and reviewed regularly by a doctor. So a plan of care is written prior to the patient coming on of the specific skilled services that the patient is going to receive. The patient must need the patient must need and a doctor must certify that they need one or more of these: intermittent skilled nursing care other than a blood draw. So what that means is a nurse coming based off the plan of care once a week, twice a week. It really depends on what that need is. So one example could be for a patient that has sepsis, they could be getting an IV medication, right? And a nurse needs to administer the IV medication, and we'll say that they're going to administer it for 10 days straight. So a nurse would come every day to administer the IV medication, not to check in how the patient is doing and how that if the IV medication is working. Their job is just to give the IV medication. Physical therapy. So if we're doing physical therapy, for an example, like for a hip fracture, then they would be doing visits to help rehab that hip and teaching how to do exercises and stretching to become more mobile, right? So again, they're not looking at the patient as a whole, a physical therapist. They're only looking at the physical rehab of what they're trying to get back to the way it was before this happened, right? So again, the physical therapist isn't looking at, hey, this patient is a hip fracture with dementia. The patient is only a hip fracture patient. Speech and language pathology. Sometimes this comes up when it comes to aspiration, difficulties chewing or swallowing, and a patient being taught how to eat or how to swallow properly to prevent aspiration, right? So again, we're not treating the dementia, we're treating the aspiration, and we're teaching how to ensure that the patient does not aspirate. Continued occupational therapy service. The condition must be expected to improve in a reasonable and generally predictable period of time. So it's time driven. There's a certain amount of time that you're going to receive these certain levels of care or these visits. And it doesn't necessarily mean that it's going to be ongoing for a year or that it's going to be ongoing for 6 months. The goal is to get the patient back to where they were before this happened, depending upon how long that might take, or is it not working at all, right? Is it not enough care for the patient as a whole? And usually in that sense, a patient ends up going back to the hospital because the symptoms become more than what is able to be managed by home health. The patient is not eligible for the home health benefit if they need more than part-time or intermittent skilled nursing care. So if you need a nurse to go 4 hours a day, 6 hours a day, 8 hours a day, 12 hours a day, that would not make someone eligible for home health, right? Just because you need a nurse. That's not what home health provides. This is another very important thing. The patient must be homebound, and a doctor must certify that the patient is homebound. The patient must be confined to the home related to a medical or physical condition. Note, the patient may leave home for medical treatment or short, infrequent absences for non-medical reason, like attending religious services, but there must be a normal inability to leave the home, or the patient has trouble leaving the home without help, like using a cane, wheelchair, walker, or help from another person because of an injury or illness. So in most of the cases I've experienced with advanced Alzheimer's and dementia patients, for good quality of life, which most of them have when they have great caregivers, is we want to take them outside. We want to take them out for a ride. We want them to have the best quality of life. If they are homebound and they cannot leave their home because they can't even get out of bed, or they spend the majority of their time in a chair all day, what kind of quality of life is that? And the goal is for them to be able to live the best life they can. So to be able to go outside and smell the roses, to be able to go and visit other family members, to be able to safely evacuate their home if there was an emergency, right? So home health is specific to, and for my grandma, the reason that she would qualify for home health is because she fractured her hip. And so she's not able to walk around or get out of bed on her own without additional support or help. So home health care is a wide range of healthcare services that can be given in the home environment for an illness or an injury. Home health care is more convenient and just as effective as care you get in a hospital or a skilled nursing facility, where, well, it is convenient if you have caregivers and someone staying with that family member 24/7, because in a hospital or in a skilled nursing facility, that's what they have. They have staff in the hospital 24/7 or in a nursing facility 24/7. Whereas at home, you do not have that. You just have the loved one or whoever's providing the care, or sometimes even patients your loved ones live on their own, right? So it can be convenient in a sense where they come to you and you have a caregiver that's able to also get the other things that you need, like helping you get food cooked or helping you bathe or helping you use the bathroom if necessary. So I don't know necessarily that I would agree that it's convenient or just as effective, but these are my own personal thoughts. Examples of skilled home health services include wound care for pressure sores or surgical wound, educate, teach, and train patients and the caregivers, intravenous IV antibiotics or nutrition therapy, injections, monitoring serious illness and unstable health status. So another example where home health may be beneficial is for an advanced cancer patient where they, because of their cancer, are experiencing nausea, vomiting, diarrhea, or some things that they might need IV fluids, right? Or they might need some additional skilled nursing care in the home. So what services does Medicare home health provide? Medicare coverage criteria require that the patient receive at least one qualifying skilled service, and a skilled service is defined as a service that requires the skills of a clinician for safe and effective performance. If the average non-medical person without specific training can perform the procedure, then it would not be considered skilled. A skilled service may include nursing service, physical therapy, speech therapy, occupational therapy, right? So all these nurses, physical therapists, they all have a license to provide that level of care. And it's can only be ordered or can be given by these types of skilled service if it's something that a non-medical person would not be able to do. So home health for dementia patients. Home health care can be ideal service for patients with mild to moderate dementia. Mild dementia is marked by being able to participate in all 6 activities of daily living. Moderate dementia is marked by ongoing cognitive decline and some difficulty with 1 to 2 activities of daily living. So we are looking at the ability to dress, bathe, eat, transferring, ambulation, and incontinence. So home health would be beneficial for mild dementia or moderate dementia, but would not be recommended for advanced dementia. The goal of palliative care. So the goal of palliative care is helping patients to achieve and maintain maximum physical, emotional, spiritual, vocational, and social potential despite the progression of their terminal illness. Palliative care provides relief from pain and other symptoms, affirms life and regards dying as a normal process, neither hastens nor postpones death, integrates the psychological and spiritual aspects of care, provides support for patient and family, uses a team approach to address needs, will enhance quality of life, and may also positively influence the course of the illness, is applicable early in the course of illness in conjunction with other therapies. So for palliative care, Palliative care is for those with advanced illness, but that are still receiving or wanting to receive aggressive treatments. So some examples of aggressive treatments for dementia patients would be if you have a neurologist that's still running tests or exams to see what can be done to slow the progression of the dementia, right? There's not a cure for dementia, but if you are still seeking specialist care and the specialist is doing things in order to slow the progression of the dementia. Another example is if your loved one has difficulty eating on their own and you want them to have a feeding tube placed. A feeding tube is considered for dementia patients an aggressive treatment because there becomes a point in time with dementia patients where their body no longer needs that form of nutrition, because we use nutrition for energy. You need less energy if you're in bed all day, right? Or if you're not as active as you once were. So there could be a lot of challenges with placing feeding tubes in patients with advanced dementia, rather than letting the disease take its normal progression, right? So that would be considered an aggressive treatment. So you're doing a surgical procedure to place a feeding tube, and we are artificially feeding that patient. I think what else? Another example is palliative care could be good with an advanced dementia patient that even with decline, you still want to go to the hospital and you still want them to be intubated and resuscitated. And so they do not have an out of hospital, do not resuscitate yet. So they could have advanced dementia where they're experiencing more symptoms like hallucinations or they're experiencing sundowning. Palliative care is able to prescribe medications that help with the symptoms of dementia. But if your loved one said like, hey, no matter what, we know what's going to happen with my dementia, I still want to be resuscitated, I want to be intubated, I want a feeding tube, I want all of these things, then that's when palliative care would be that option. So when we're looking at palliative care versus curative care, we're looking at palliative care as being symptom driven, comfort and quality of life. The patient is in charge, or in this case with dementia, the family. Disease process is secondary to the person, and there are many choices. Curative care is disease driven. Curing the disease is the main concern. The doctor is in charge. So in this case, a neurologist would be in charge of what are we going to do to cure dementia. Disease process is primary. So we're looking at how the disease is progression, and there are fewer choices. Palliative care realized. This goal is fully realized when the patient experiences the following: relief from pain, psychological and spiritual care, a support system that assists the patient with being as active as he or she wishes, a support system that sustains the patient's family. So with palliative care, the patient does not have to be homebound. The visits are intermittent, and at the end of me going over all of this, I'll kind of show you a little chart of the differences in the levels of care that's easier to see versus all the words that I'm going over. But the plan of care is very limited. So if something happened at 4 a.m. and there was a symptom and your loved one was hallucinating or sundowning, palliative care would not come out and try to alleviate those symptoms, right? So you would still call back to your primary care doctor and you would report that to your primary care doctor, and the palliative and your primary care doctor would work together in that aspect. So palliative care is an additional service, but at the end of the day, the main care comes from the primary care doctor. The palliative care reports to the primary care doctor, and then the palliative makes recommendations of medication management to the primary care doctor. So it's an additional level and layer of support, but that's all going through the primary care physician. And it's not 24/7 care. it again is still intermittent visits based on the need of the patient. And it could be one visit from a nurse a month. It could be a social worker doing one visit over a 6-month period, right? So there's not specific rules that state this is what palliative care has to do, but they're not a 24/7 lifeline. We would still continue to, in the event of an emergency, call 911 and go to the hospital. So the goal would be to keep your loved one at home, and you also don't have to be homebound. So the goal would be to keep them as comfortable as possible, making sure that they're sleeping well, making sure that they're not, that their symptoms are being kept to a minimum, but you still are going to continue on with the aggressive treatments. You're going to still continue on with neurology. You're still going to continue on with going to the hospital. So hospice and palliative care misconceptions. Hospice and palliative care means doing nothing. All treatments are discontinued and all invasive interventions such as chemotherapy or radiation are stopped. Or in this case, again, with dementia, we stop, if the patient stops eating, then that's the course of the disease process, not that we're starving them. Based on where the condition of the patient, that might not be something that they are still needing, right? They're not needing that same level of nutrition. It doesn't mean that you can't go to the hospital, even if they're on palliative or on hospice. A hospice patient, if you decide that you still want to continue aggressive treatment, can still go to the hospital. You still have that right. But the goal is quality of life and comfort. So we are going to be managing the symptoms and the disease progression to make sure that the patient has the best quality of the life and that the caregiver has all the resources and has a lifeline when you don't know what to do because you're not a skilled licensed professional, or sometimes you are if you are a daughter and a doctor. But at that time when you're caring for your loved one, you're not a doctor, you're a daughter. And hospice and palliative care allow you to be that. So the Medicare hospice benefit was passed by Congress in 1982, and hospice provides 4 levels of care: routine home care, continuous care for symptom management. So it would be a clinician in the home for 8 to 12 to 24 hours a day until the symptom is under control. So hallucinations, sundowning, pain, nausea, vomiting, diarrhea would be symptoms that we would try to control with medications. But if we couldn't control, then we would stay at the bedside until we could get those symptoms under control, or we would transition to inpatient care. So Medicare requires that we provide inpatient hospice care, and it's somewhere where we take the patient and we take over that 24-hour care with hospice professionals, doctors, nurses, to get the symptoms under control. So it's a place for patients to go that need symptom management. Once the symptoms are under control, then you transition back to routine home care. And then there's also respite care. So for those of you that are caring for your loved one in the home, and let's say for yourself, you have something coming up, or an example, like when I went and stayed with my grandma for those couple of days, respite would have been a great benefit for my aunts to use during that time, because during that time something came up that they could use someone to help assist. 5 days for 5 days, you go to an inpatient facility such as a nursing home, and the nursing home provides care, 24-hour care to that loved one during that time. And again, it's based on the need of the patient. So there's emergency respite. Sometimes things come up and you have to travel out of town to go help another loved one, or there's a graduation, or you even need to take care of yourself. You have your own doctor's appointment or your own surgery, or even just, hey, I love you so much, but I need a break. I need a mental break to recoup and refresh and be able to take on this 24/7 duty again. And it doesn't mean you just drop them off and you never see them again. You can go and visit them. You can go and see them. The hospice team will touch base with you when things are going on, but it's also a good way to help with integrating into placement. So for some, placement is the option. or replacement is the need to care for a loved one. So if your loved one starts experiencing temporary visits to these skilled facilities and they get used to the facility or they get comfortable with it, transitioning them into living there is easier when they've been there a couple of times. So the respite helps with that transition to placement. Hospice is required to cover 100% of costs related to the terminal diagnosis, which includes the home medical equipment, medications. There's unlimited benefit periods, and services are primarily reimbursed on a per diem basis. So hospice is based on a daily rate of care, and the only time that that's changed is if we provide a higher level of care. So it doesn't matter. Every hospice receives the same amount of dollars, no matter what hospice you pick, for providing the 4 levels of hospice care. We all receive the same amount of money. But the visits, the plan of care is surrounded by the patient. So if your loved one is experiencing symptoms or something's going on, or we need a nurse to visit more than 2 times per week or more than once per week, hospice is allowed to write in that plan of care at any time that the patient needs more frequent nursing visits and why. We're not going to receive any additional reimbursement for the additional nursing visits because it's our responsibility to manage the patient 100%, the patient as a whole. So hospice Medicare covered services, skilled nursing services. So we have an RN case manager for all of our patients. A physician visits. So we have hospice physicians that oversee the care of the nurses and are able also to go out and do visits with patients. Hospice aid visits, volunteer services, medical social services, spiritual counseling, nutrition counseling, bereavement support for families. All services are provided based on the needs of the patient and the family. So these are all the things that hospice offers. The only thing that Medicare requires that we do is that we see a hospice patient, a nurse, at minimum once every other week. So it's your decision whether you want a home health aide. It's your decision if you want a social worker. It's your decision if you want the chaplain to come out. So these are all additional resources that we have to make the hospice experience the best experience. And the earlier that you get on hospice, it might be good at first with having a nurse visit once a week and managing medications and making sure that medications are managing the hallucinations and the sundowning and the things that are happening. And as time progresses, you might see that you need more help and support. So yes, I need an aide to come and help bathe mom because I'm having difficulties getting her out of bed myself, right? And then, with social work, I'm needing other family members to help with providing caregiving, and I need to help with FMLA paperwork filled out, or I need help getting a handicap placard, or I need Meals on Wheels, or I need food. So our social workers are able to help with that. But again, it's up to you if you want social work services. It's up to you if you want a chaplain to come out and do prayers, or to just even talk and be that support. So the care that hospice provides is based on the needs of the patient and family. And every patient and family could have a different set of visits, right? Depending upon the need. So I want to ask you right now, is your loved one having trouble communicating or speaking? Are they spending most of the time of the day in a bed or a chair? Are they confused and or spending more time sleeping? Are they unable to walk, get dressed, or bathe without maximum assistance? Are they incontinent of bowel and bladder? Are they having difficulty swallowing or refusing to eat? And in the last 6 months, have they visited the emergency room or been hospitalized? Or have they lost weight unintentionally? If you answered yes to any of those questions, your loved one may be eligible to receive hospice services. So when you look at this very simple chart of everything that I've just said. And it has the differences between VITAS, hospice, palliative care, and home health. The eligibility requirements for hospice is that a prognosis is required of 6 months or less if the illness runs its usual course. Again, we don't have a crystal ball, but because hospice has an unlimited benefit, if your loved one does not pass away within that 6 months, it's okay. It doesn't mean that we're going to discharge you from services as long as the patient their disease is still progressing at its rate. And for every dementia patient, it could be 5 years, it could be 3 years, it could be 2 years, it could be 1 year, it could be 6 months. But ultimately, what we're looking at of the prognosis, would we be surprised if our loved one or if the patient passed away in 6 months or less? A skilled need is not required because we're looking at the diagnosis of the patient. So what is the diagnosis and what attributes to that diagnosis? That's what we're bringing a patient on to hospice for. The plan of care is quality of life and defined goals. The length of care is unlimited. You don't have to be homebound. It's a targeted disease-specific program. So we're providing care on a patient with dementia and everything that's involved with their dementia or anything that's attributing to their dementia. We provide the medications, we provide the medical equipment, we provide after-hours staff availability. So 24/7, if anything happens, Thanksgiving Day, July 4th, Saturday, Sunday, 4 a.m., because nothing happens Monday through Friday from 8 to 5, like literally nothing. Unless you're a kid. Hospice provides the support 24/7, and we will send a nurse in the middle of the night to come and do a visit, or a social worker or a chaplain. We are able to provide a respiratory therapist, a physical therapist, an occupational therapist, or a speech therapist if that's what's needed for the best quality of life. Nurse visit frequency is unlimited. So we're basing our nurse visits based on the need of the patient and the family. And there's no one saying, VITAS can't send a nurse 7 days a week if that's what's needed for the patient. Palliative care physician support, there's 4 levels of care and we provide bereavement support. For palliative care, the prognosis varies by program and is usually life-defining illness. A skilled need is not required. Again, we're looking at quality of life and defined goals. The length of care is variable. So palliative care is not forever, right? There's usually a transition. So are we transitioning from palliative care to hospice because we're no longer seeking aggressive treatment and we're okay with the disease progression? The disease-specific programs could be variable. So every palliative care program can do it however they want. Medications are not included, so you would still order them from your PCP. Equipment is not included, so you would still get that through your DME company. There's no after-hour staff availability. There's no licensed clinicians for RT, PT, OT, and speech. Nurse visit frequency is variable. Palliative care physician support is variable. There's only one level of care, and there's no bereavement support. For home health, a prognosis is not required. Skilled need is required. We're looking at restorative care. That's the plan of care. The length of care is limited with requirements. It's required that a patient be homebound with the exceptions that I provided. There's a variable. Every home health could have different disease-specific programs. Medications are not included. You order them from your PCP. So even if there needed to be a medication change, the home health nurse would have to call your PCP to get the order for the medication. Equipment is not included, so you would still have to get your own medical equipment. There's no after-hours staff availability. So it's specific to the skilled need. The nurse is only going to come at their set visit date and their set visit date at their set visit frequency. They do provide physical therapy, OT, speech, again, based on the skilled need. The nurse visit frequency is limited based on the diagnosis. So based on the restorative need and what we're trying to restore, there's no palliative care physician support. There's only one level of care, and there's no bereavement support. And my presentation today is in memory of my Mima Edna, who was born on July 30th, 1931, and passed away on January 15, 2023. And just to add, we almost shared a birthday, but my birthday is July 31st. So for 36 years, I shared a birthday with her my entire life. Thank you so much for having me and allowing me to do this presentation today. So now let's have some questions.
Well, that was a beautiful presentation and very personal. Thank you. Would you like me to read stuff from the chat room, or would you like to take it yourself?
Sure, go ahead.
Would insulin shots for diabetes qualify? And I believe that was under home health care.
So again, it depends on the need, right? Is it that there's just nobody that is able to provide the insulin shots? So usually when it comes to insulin, that's something that can be managed at home by by a non-clinical professional.
And many times people are discharged from the hospital with the assumption that the caregiver can provide the insulin shots. But I know we have another presenter who said she just is scared to death of needles and she couldn't do it. So home health came and provided it.
And it should be for teaching. So it's to teach the family how to provide the insulin shot. So it's for a limited amount of time. It's not forever.
And Natalie had another question. She says, is assisted living considered homebound if that's where they live?
So are they able to, so that's where they live, but are they able to leave the assisted living?
That's the question.
Yes, yes, he can leave. He's wheelchair bound though. So someone would have to pick him up. It's not like he comes and goes as he pleases, but he is allowed to leave. Yes.
Okay, so yes, I definitely have seen many patients in assisted livings that receive home health services. And there's also assisted livings that have home health services that are inside their building. So they wouldn't even have, like, it's part of the assisted living. Like they have a contract with the group to provide it there to the patients in the facility.
Okay. Yeah, they've mentioned that. I didn't know if that was connected to home health or if that was totally separate.
Yeah, and so usually what we'll see is, for weakness, I've seen like they're getting a little bit weaker than they, and so they want to keep up that strength. Or even for patients that are in wheelchairs, like I've seen that maybe they fractured their wrist or they've had some challenges with mobility. That's a lot of the time when I see home health used for dementia patients in assisted livings.
Okay, yes. And I guess that sort of ties into my next question is, if there was no injury, like there was no fall or they didn't break anything, they're just physical capacity is rapidly declining, would they still do physical therapy knowing it's probably never going to get better?
So yes, if you allow it.
Okay. I mean, I'm for it all day, but it's just, it's not going to get better. So I just don't know if does that stress them out? Does that stress the dementia patient out? Are they even aware of what they're doing,
And so it's good to communicate with those that are providing the therapy to see if there's actual true progression. And also what could possibly tend to happen is what if they do end up breaking something or something, some kind of adverse reaction to them being pushed to do these therapies.
Yes.
But really,
okay.
Either way, for whatever decision you all choose, it's your option. It's your option to do home health and to continue home health. It's your option to do palliative care. It's your option to do hospice, right? So with all of these, it's your option and you have the right to say, yes, I want this, or no, I don't want this, or yes, I want this company, or no, I don't want this company. It is not the doctor's decision. It's your decision. or whoever the speaker of the patient is.
Okay, awesome. Thank you so much.
Well, and Natalie, I've seen cases, having been a social worker for over 50 years, where the physical therapist will come out and they're basically doing range of motion just to maintain a person, not to, they're really not going to get better and everybody knows it, but it's maintaining at least
Yes,
the ability
yes.
that they have right now.
Okay, because that's kind of the point we're at, but I didn't know if they would, take a person away from someone else who possibly could get better. I just don't know if they make it seem like there's a shortage. And so the patient really needs a need for that physical therapy when, you and I know it's probably just that. It's probably just the range of motion, just the basic day-to-day to get him, to in and out of the wheelchair.
And that makes it easier for the staff. And so we even have scenarios in some assisted livings where, depending upon the diagnosis or what they're going to be skilling the patient for, does it attribute to the hospice diagnosis and what we're covering? And maybe the PCP ordering the home health separate from hospice based on what they're doing it for.
Okay, that makes sense. Thank you.
Okay, folks, we have an expert. You can ask your questions. Please, if you're on the phone, press *6. We would love to hear from you. And if you're on Zoom, you know what to do. And we've got a couple people on the phone. And I've got a little website where I can see if you want to talk to us. Okay, Janice.
Janice, yes. Hi, Evelyn. Good to see you. I am wondering if there's a handout on this program. This is a very educational program. I'm a private caregiver, and I deal with families and they don't know and would like to know very often. One of the cases I'm on right now, there's such a big dilemma as to what to do, when to do it, how to do it, blah, blah, blah. It all goes on. This program, thank you, Candance. Very, very informative. I think I've learned a thing and more even over 15 years of practice. So.
Wow. Now, Candance, are you allowed to share your presentation with folks? Is that something we could send out to them?
Sure, why not?
Even
I
that
will
last chart, that last chart was really cool.
Yeah, so I have a couple. If you don't want the whole presentation, I do have a couple of just simple handouts if that makes it easier, but I'm more than happy to share my presentation.
Okay, if you send me those, I'll make sure folks get them. And I don't have any more questions here right now, but I know people are still thinking. So let me do a little bit more housekeeping. This is the stuff that everybody says. We've already heard this a million times. Thank you, Janice. You're going to get a questionnaire in the next week as one of our participants. And it's really important to us that you fill that out because it helps us improve all the time. So we hope that you'll take them seriously. However, the resources come with the questionnaire. So if you aren't registered, you won't get the resources that Candance is going to share with us, nor will you get the monthly calendar, which is pretty fabulous. So I totally recommend that you call the WellMed Charitable Foundation's customer service representative if you got this number or the link from somebody else and get registered for our sessions. And that number is 866-390-6491. And you will not only get the questionnaire, the resources, but I have to tell you, we have 13, this was the first one, 13 sessions scheduled this month. And they are just covering all kinds of different bases. And you'd be so happy, to see what's on this monthly calendar and be able to pick and choose, what you need, what works for you, and share it with your friends, other caregivers that you know. So we would really like to have you call in and get registered. And I can share a couple upcoming sessions, but first I see that we have another chat. So let me go see what that is. Can you please repeat the number? Oh, I'm sorry. Yes, the WellMed Charitable Foundation customer service representative is at 866-390, thank you, Minerva, 6491. And the website is, I'm so happy you typed that underneath. because it's a little bit long. Caregiver Teleconnection is one word, .org, but that's where the podcasts are. So we encourage you, share that information with anybody, everybody, because for caregivers, and there are more of us every day as the population ages, for caregivers, this is a treasure trove of information. Anybody else? Okay, then I'm going to do just a few of our sessions so that you guys have some idea of how cool these are. We've got a series from two of our experts. Our Health is Our Wealth, a health promotion series for caregivers by Elliot Montgomery Sklar, who's a PhD in public health, and Lucy Berlac, who's a social worker. And they're going to be 4 sessions every Wednesday at 8 o'clock. Nutrition, physical activity, mental health, and stress management. Not that any of us are stressed. And then on, this afternoon at, Central Time, 1 o'clock Central Time, Dr. Tam Cummings, who's a huge professional in dementia, has a great reputation. She's going to let you just ask her questions. So it would be really cool if you have a lot of questions about dementia if you log on to this afternoon. We also have caregiving for people with Parkinson's disease, 10 warning signs of Alzheimer's disease. We're having a totally Spanish session on Tuesday, April 11th, Dementia and Family Dynamics with Dr. Pradario, who will present in Spanish. We have Dear Lucy, Dementia and Inappropriate Sexual Behaviors. We have why caregivers should confront, not avoid, early diagnosis. It's a really important topic. Dementia and ambiguous loss with Dr. Natalie Oliver, how to develop a growth mindset as a caregiver with Jamie Heisman. Oh no, that's not the name anymore. Let me see. Last month, Jamie Heisman did one on how to get toxic people out of your life. And I want to say, it was a pretty incredible presentation. And I kept thinking to myself, well, I've got a brother who's really toxic. How do you do that? And now this session, it's part 2 of that session. And he's going to tell us, what is the key when there are people that you're close to or that you're supposed to be loving? How do you get them out of your life? So it should be a very interesting presentation. And that'll be on Thursday, April 27th at 1 o'clock Central Time. So with that, unless somebody has some additional questions or comments, I'm going to stop the recording and end the session. And Candance, I really want to thank you so much. You did a beautiful job. I want to thank the participants who are so wonderful. We've got just a community growing here now, people who attend fairly regularly, and they always help make this a better presentation. And I want to thank the WellMed Charitable Foundation for the wonderful, generous things that they do for caregivers around the country. So thank you all. We hope to see you again soon at one of the up and coming sessions. Bye-bye. Thank you, Candance.
Hi, thank you.